Hello, everyone. Thank you for joining us. Welcome to the Avexia webinar series. Our topic for today is Mastering Mercury with Quicksilver Scientific, Part 2, Beyond Challenge Testing with Quicksilver Mercury Tri-Test. My name is Christopher Chu. I'm the Director of Marketing for Avexia Diagnostics and will be your host for this webinar. Today, I have the distinct pleasure of being joined by an exciting guest, Dale White, who will be our presenter for the webinar. Dale is a California state licensed acupuncturist with over 40 years of clinical health care experience in bodywork, nutrition, herbal, homeopathic, acupuncture, and functional medicine studies. He has worked in a variety of clinical settings, including halfway houses for mentally ill, AIDS clinics during the epidemic, a hospital chronic pain clinic, as well as private practice. In 2015, Dale joined Dr. Christopher Shade as a clinical consultant for Quicksilver Scientific, providing physician education on test interpretation, products, and protocols. Without further delay, I will now turn the webinar over to Dale.
This is our agenda for the three-part series, and today we are looking at part 2, Beyond Challenge Testing with the Quicksilver Mercury Tri-Test. With regard to testing mercury, there are different types of mercury tests. We're going to look at different types of mercury tests, the mercury testing myths and limitations of mercury challenge testing, and ending with the mercury tri-test. So we can use 4 different samples for testing mercury: blood, urine, hair, and stool. When we're using blood, with exception of the Quicksilver Scientific's mercury tri-test, when you are testing blood, the sample will show the total mercury in the blood. If you recall from part 1 in this series, mercury exists in the human body in 2 different forms: methyl mercury and inorganic mercury. And if you do a test through LabCorp or Quest or anyone else other than Quicksilver, what you'll be measuring in the blood is the total mercury in the blood. However, remember that by far the most dominant form of mercury in the blood is methyl mercury. When we're using hair, we're measuring methyl mercury only. When we're using urine, we're measuring inorganic mercury with a very small component of methyl. And when you're using stool, that's pretty messy, but you're looking at total mercury, the combination of the 2 forms. The other way of looking at or testing for mercury is using challenge testing, provoking agent, a chelating agent. And when you do that, you do a urine collection, and you'll be looking again at the sum mercury, the combined inorganic and methyl together. So let's look at some myths of mercury testing. Common one is that blood only shows a recent exposure. The reality is that blood is an accurate testing method. It's an accurate reflection of the mercury burden, or what's in the tissues. After a large dose, for example, some large predatory fish like swordfish or tuna, sea bass, you'll see blood levels go up quickly. They'll spike at about 24 hours and then decay or decline over the next 72 hours. And provided you don't add any more, you don't eat any more fish or have any other kind of exposure, then that is going to decay back to a baseline, taking more than 160 days. So provide you don't put any more in, or you don't start actively detoxing, then you'll see that decline back to baseline more than 160 days. The initial decay reflects mercury moving from the blood into the tissues. So the mercury is crossing the vascular membrane into the tissues. After the initial decay, or that first 72 hours, mercury or methyl mercury will develop a steady state. The concentration gradients will equilibrate between the blood and the tissues. In other words, blood is reflecting a tissue burden. The gradual decay, that is after the first 72 hours, that's reflecting the conjugation of mercury to glutathione and the excretion. This is the equilibrium between the blood and the tissues. For inorganic mercury, the blood level is reflective, but it's a little bit kinetically delayed, so that during detox, the blood level will look a bit lower than the body burden. The real problem is that most labs' detection limits are too high to see these dynamics. So what you need is more sensitive equipment. So here is the great tuna experiment. You see the dark blue bar is the pre-tuna. Then we sat down and ate 2 cans of albacore tuna in one sitting and then started drawing the blood. At 2 hours, you see a more than doubling of pre-tuna, pre-ingestion concentration. Then at about 24 hours, you see a spike. Then over the next 72 hours, you see the equilibration between the blood and the tissues. And that's what this line is demonstrating. Another myth is challenge testing is necessary to show mercury hidden in the tissues or to find the hidden body burden. The body burden is conceptualized as our lifetime accumulation of stored mercury. So the assumptions for that, number one, mercury gets into the tissues and builds up over a lifetime. Now, we just dispelled that assumption with the previous few slides. We see that that's not really the case. The methyl mercury is equilibrating between the blood and the tissues, and the inorganic mercury is a little bit slower, but still over time equilibrating. Another assumption is that a challenge agent will bind metals, in this case mercury, in the tissues in proportion to their level and eliminate them in the urine. This means that a challenge agent must either, one, be able to enter into all the body compartments in which mercury is stored and uniformly draw them in proportion to the amount stored. Or two, challenge agent must remain in the blood for an adequate amount of time such that mercury is proportionately released from the tissues and then bound by the provocation agent and into circulation and then bound by that chelating agent. So, question, do chelating agents enter into all body compartments in which mercury is stored and uniformly draw them from proportion in the amount stored? What does the research say? This study looked at 4 groups exposed to mercury vapor. We have the acutely exposed workers in chloralkali plants, dentists with chronic exposure over 30 years or more of working with amalgam, a group with amalgams, and a group with no amalgams. The concentration of inorganic mercury in the blood is graphed horizontally, and the concentration of inorganic mercury excreted in the urine is graphed vertically. This study hypothesized that with a challenge test or with a chelating agent, The excretion concentration in the chronically exposed group, that's the dentists, would merge with the acutely exposed group, that's the chloralkali workers, revealing an accumulation over time that is a body burden. However, that is not what their data demonstrated. The pre-challenge versus the post-challenge excretion demonstrates a linear relationship. The challenge testing method is only amplifying the signal that is already demonstrated by ambient blood testing. Therefore, challenge testing is not required. What is required is a more sensitive testing method. The mercury excretion provoked by D.N.B.A.O intake was well associated with the pre-D.N.B.A.O mercury levels in the plasma and the urine. As the latter are mainly indices of mercury exposure during previous weeks or months, the same should hold true for excretion induced by D.N.B.A.O. Our hypothesis was that the body burden and thus the long-term exposure would be reflected by the D.N.B.A.O mobilization test. However, this hypothesis was not supported by our data. Another question, do chelating chemicals remain in the bloodstream an adequate amount of time such that mercury is proportionately released from these tissues and bound by the provocation agent and bound to the mercury in circulation? Chelating agents are fairly rapidly excreted over a few hours or days. In contrast, toxic elements may have accumulated over long periods, so this is where they're still thinking of the body burden. The main thing we want to see here is in red. A chelating agent will mobilize the most readily available metals first, typically in the plasma, kidney, and liver, and then to a lesser extent, the bone and central nervous system. Reequilibration slowly replenishes the toxic elements in more accessible body compartments. After treatment with DMSA or DMPS, mercury has been observed to redistribute from the soft tissues, that is the liver and kidney, into the nervous system. The higher levels of neuronal inorganic mercury may be due to increased entry of mercury into motor axons across the neuromuscular junction as a result of chelator-induced elevated circulating mercury. So we have some issues with challenge testing. One is a lack of standardization of challenge testing protocols and lack of standardization of testing interpretation. Challenge testing does not distinguish between inorganic and methyl mercury. Challenge testing is dependent on variable renal elimination. The challenge agent may cause redistribution of toxic elements and harm due to this and other reasons. And there is a limited ability of challenge agent to access different tissue spaces or different compartments. Therefore, when is challenge testing actually warranted? It's warranted when you're testing for, it may or may not be warranted when you're testing for lead or gadolinium. EDTA challenge testing is documented to have slightly better correlations with bone lead than blood lead measurements. Gadolinium levels are typically undetectable without EDTA provocation. DPTA is the most specific chelator to gadolinium, but it is almost impossible to get. It's mainly for research. Challenge testing adequate and inaccurate. The literature has failed to find any evidence that challenge testing reveals any more than a recent exposure. Challenge test fails to meet its objective and poses possible significant health risks. So we need a better solution. Utilizing advanced mercury speciation analysis, Quicksilver's patented Mercury Tri-Test is the only test that separates and quantifies the concentrations of both forms of mercury in the blood, the methyl and the inorganic, as well as the excretion in the urine and in the hair. The sensitivity of Quicksilver instrumentation eliminates the need for challenge testing with potentially harmful chelating substances. So in order to see the complete picture of mercury toxicity in our patients, we need to see the steady state level of both forms of mercury and also the patient's ability to excrete them. This is important because both those forms of mercury come from different sources. They have different relative toxicities and they're excreted through different organs. The mercury Tri-Test shows the concentration of both forms in the blood, allowing the practitioner to identify where it's coming from. What's the input? It's important to see so you can eliminate that input. The mercury Tri-Test shows a concentration of mercury being excreted, so you can evaluate the patient's excretion and support those different organs if necessary. This helps you develop a more appropriate protocol and avoid exacerbations. Quicksilver measures both methyl and inorganic mercury directly with liquid chromatography coupled to cold vapor atomic fluorescence spectrometry. The Mercury Tri-Test report consists of 2 pages. Page 1 represents your patient's results, and page 2 is an interpretation guide. In part 3, we're going to cover interpretation of the Mercury Tri-Test, and I look forward to seeing you then. This is a quick overview of page 1, showing you, identifying where different data is. We're going to cover that next time. I'll see you then. Thank you for your attention.
For any questions or issues you may have, please contact Avexia Diagnostics by email at info@avexiadiagnostics.com or by phone 5 days a week at extended hours, 8 a.m. to 8 p.m. Eastern Time at 888-852-2723. Thank you, Dale, for this informative presentation. Thank you again for joining us for this webinar event. Until next time, from everyone at Avexia Diagnostics and Quicksilver Scientific, stay healthy, stay safe, and we wish you all the best on your pathway to wellness. For any questions or issues you may have, please contact Avexia Diagnostics by email or info@avexiadiagnostics.com or by phone 5 days a week at extended hours, 8 a.m. to 8 p.m. Eastern Time at 888-852-2723. Thank you, Dale, for this informative presentation. Thank you all again for joining us for this webinar event. Until next time, from everyone at Avexia Diagnostics and Quicksilver Scientific, stay healthy, stay safe, and we wish you all the best on your pathway to wellness.